Hello everyone, my name is Jung-Ho Lee. My paper title is the effect of feedback application on activity function in patients with neurological impairment. Let's start my presentation. First is the introduction. The motor learning refers to a series of processing ability associated with practice and experiments that include induced relatively performance change to movement-related abilities. Additionally, this process involves a series of events that induce concurrent output states and changes, and they are divided into several categories based on their characteristics. Various measurement tools has been used in many studies to probe the effect of motor learning and related variables. Among them, serial reaction time task has been frequently used to identify elements that affect motor learning, such as amount of practice, kinds of feedback, and plans. Serial reaction time task distinguishes between learning implicit knowledge and learning explicit knowledge. In particular, as one of the most widely used motor tasks in field of cognitive science and randomized design and block design can be selected used to examine procedure learning effects and depends on study purpose. When acquiring motor skill, movement speed, and accuracy increase, leading to automation and adaptability, thus behavioral change result from change to brain function through motor learning. Additionally, when motor functions are lost due to brain damage, the motor skill can be restored through external therapeutics interventions alongside natural recovery, and this restoration is called motor learning. In this learning process, feedback from within and outside of body plays an important role. Feedback provides information about the learner's knowledge of results and performance when learners perform tasks. Sometimes feedback is classified according to information types. Numerical information related to the size of the performance characteristics is called quantitative reinforced information. Meanwhile, information about the status of performance, regardless of numerical value, is called qualitative reinforcement information. In the motor learning field, generalized motor program can explain how motor learning is acquired. Generalized motor program derived from the concept that motor programs stories in the brain adjusted movement to fit qualitative change in motor skill performance. This theory suggests that the value of parameters involved in movements are optimized so that movement performance more efficiently. Generalized motor programs were developed through systematic ID called Schema theory. Schema theory is a cognitive system of such systematic idea formulated as a series of results about the information necessary for movements. Motor schema theory emphasizes a cognitive aspect, holding that if the amount and the velocity of practice increase, the motor schema will be strongly acquired and new movement that has not been performed during practice will become possible. Therefore, schema can be learned through the motor learning so that movements can be performed effectively. The brain region function of the central nervous system can deteriorate or degenerated due to nervous system disease and aging, etc. Such damage to the brain's functions negatively affect muscle strength, the sense of balance, somatosensory and nervous system function, reducing the body's motor ability in functional movements and gait throughout daily life while restricting daily movements. Stroke patients experience various symptoms such as sensory disturbance, cognitive impairment, and motor disturbance, and perceptual disturbance, and speech disorders, and visual field defect, and dyspraxia. In such cases, many patients live with permanent disabilities because they cannot recover their normal movements due to spasticity and muscular weakening, thus results from motor function disorders. This factor naturally encourages the use of the non-paretic side during the activities that require substantial upper limb movement. Most stroke patients become accustomed to using their non-paretic upper limbs in their life due to a long-term decrease in the use of their paretic sides. This shift is defined as a learned behavior of avoiding paretic upper limb use. Some studies have presented exercise that can improve mobility and functional balance among stroke patients. However, this study has not clearly explained the advantage of concrete and intensive exercise programs or mechanisms that help improve patients' conditions. Additionally, even if bare hands exercise treatment methods or concrete training methods are presented to stroke patients, activity muscle contraction of their paretic sides has remained difficult, and the limitation has persisted in applying one-task-oriented training. Therefore, the present study used proprioceptive neuromuscular stimulation, which can increase nerve plasticity by stimulating proprioception, and modified mirror therapy to provide feedback. In order to investigate these treatment's effect on upper limb functions and daily living activity among stroke patients. The next is the method. To exclude the therapeutic effect of upper limbs neurological recovery, the current study examined 30 stroke patients who Brunstrom's recovery has been at least at stage 4 for the least 6 months after patient's disease onset. Each participant randomized select one of the 30 cards, 15 of which were blue and 15 of which were red. Through the method, participants were randomly assigned to experimental group or control group. The experimental group underwent a mirror therapy program after PNF for 30 minutes 3 times weekly for a total of 18 treatment sessions. Meanwhile, the control group underwent only PNF treatment 3 times a week for a total 18 treatment sessions. Preliminary evaluation of patients' holistic upper limb function and ability, as well as their daily living activities, were conducted using a Figure-Meyer assessment scale and the manual function test before the study intervention. Additionally, a post-test was conducted during the 6 weeks after the intervention has been complete. All evaluations were conducted by same physical therapist who has more than 10 years of clinical experience to maintain consistency. This study criteria for selection of participant 1 were that patients need to have met the basic standard of mini mental state exam Korean version, has no cognition anomalies of the arm or legs, will not take a cytological medication related to the depression, and could follow the researcher's introduction. The MMSE is the standardization cognitive ability evaluation tool which high relatability and validity. The motor visual perception test (MVPT) is a tool used to evaluate patients' visual field defect or hemi-neglect. It comprises 36 items in 5 areas: figure or grounds, visual discrimination, visual memory, visual completion, and spiral relation. Each item is scored with 1 point, so that the low score is the 36 point, and higher score indicate better visual perception abilities. For this study, respondents who were determined to have no impairment in visual perceptual ability, including hemi-neglect through the MVPT, were recruited as a patent. Next is the evaluation method. The Figure-Meyer assessment scale of the upper limbs was developed to quantitatively evaluate stroke patients' degree of motor recovery. It was also designed to measure motor function, balance, sensation, joint range of motion, and pain after a stroke. This measurement evaluated the patient's paralytic and non-paralytic side, and it comprised a scale of 0 to 3 points with a schedule scoring system. Higher score indicated better function. In this study, the scale's upper limb items were tested. The upper limb item comprised 18 items for the shoulder and elbow and forearm, and 5 items for the wrist, 7 items for the hand, and 3 items for the upper limb coordination. The maximum score of 66 points and the scale's degrees of recovery can also be expressed as a percentage. The manual function test was developed to measure and record change in stroke patients' upper limb motor function. Not only can it measure short-term change in patients' neurological recovery, period, but it is also a widely used tool in measuring upper limb function and movement ability. This study used the tested stroke upper limb function assessment, which comprised 4 items for upper limb movement, 2 items for grip strength, and 2 items for finger manipulation, and it evaluated both upper limbs together to predict the level of function recovery. Next is the treatment method. This study used the patient's PNF pattern to develop a therapeutic intervention. To perform an upper limb extension, adduction, and intrusion pattern, patients were asked to adopt a hooked posture in which the hip and knee joint were bent in supine position. In this hooked posture, the right arm on patient's movement side was opposite at 11 o'clock position, and the left arm was placed comfortable next to the body. Next, the upper limb extension, adduction, and intrusion pattern was performed according to the researcher's introduction. To perform an upper and lower limb combination pattern, patients were asked to place their left lower limb on the therapist's leg with their hip and knee joint at 90 degrees of flexion in supine position, and to adopt the upper limb extension, adduction, and intrusion patterns started. Posture with their right upper limb, bring their right upper limb into contact with the therapist's hand. This movement started with the therapist's verbal introduction, and the upper limb extension, adduction, and intrusion pattern, and lower limb extension, adduction, and extrusion pattern were performed simultaneously. To perform a grouping pattern, participants were asked to adopt a starting posture with their thoracic side shoulder joint performing flexion, adduction, and extrusion, following by scapula anterior elevation, elbow joint extension, supination, and wrist flexion, radial deviation, and non-thoracic side scapular flexion, adduction, and abduction, and extrusion. Participants were also asked to hold and move their left wrist. Participants were asked to adopt a final posture with their thoracic side shoulder joint extension, abduction, and intrusion, scapular posture descending, elbow joint extension and pronation, and wrist extension rotation. This grouping pattern was performed with both hands alternately. For this study, mirror treatment, participants in the experimental group took a sit position on a chair. Mirrors were placed vertical 10 centimeters away from patients on the surgical plane on the desk. To apply a modified mirror therapy, 2A mirrors were used so that patients' thoracic and non-thoracic sides were reflected in the mirrors. Patients' non-thoracic and thoracic hands were placed between the mirror, and the patients were asked to maintain a neutral line. When the first treatment started, patients were asked to stare at their non-paralytic upper limb reflected in the mirror. Thereafter, the patients were asked to stare at their paralytic upper limb while performing the same movement as this performed with the non-paralytic upper limb. Paralytic and non-paralytic arm pronation and supination, wrist and finger flexion and extension movement were scantily performed. Additionally, feedback was given by therapists to patients, while the therapist verbally explained the error in their movements. First is the result. The difference between figure-mile assessment score before and after treatment in the experimental group and the control group were significantly, statistically significantly changing. When the effect of therapeutic intervention were compared, there were statistically significant difference in the amount of change between the experimental group and the control group. There was statistically significant difference in the manual function test before and after treatment in the experimental group and the control group, respectively. When the effect of therapeutic interventions were compared, there was no statistically significant difference in the amounts of change between the experimental group and the control group. Last is discussion. The ability to identify daily perform daily living activity refers to the ability to perform activities independently in one's life, such as mobility, self-management, communication, and the use of the environmental tools. The main goal of extremely rehabilitation for stroke patients, independent living, and the acquisition of the skill needed to perform the most basic daily living activities. Interventions to help stroke patients with upper extremity movement control and functional improvement has been proven to support the neural circuit reorganization reported through the change to the neural network. The degree of patients' recovery of their upper limb function depends on the degree of paralysis in the early stage of stroke. Most recoveries started in the proximal region, and the motor functions of proximal region has been reported to recover faster than the distal region because the activation of the ipsilateral cortical spine tract and the cortical reticular tract are present in the normal hemisphere is easier in the proximal region. The recovery of hemiplegia patients' neurological function is mainly achieved through reorganizations of the neural networks, which results from the comprehension replacement of damaged neurons' function by the less damaged neural network. To promote such a reorganization of a damaged brain, the damaged region should be externally stimulated through the motor intervention. Brain tissue damage due to stroke do not regenerated as a new brain tissue, and most patients cannot evade it scarcely completely. However, they can recover to the extent that they can lead a daily lives. To that end, they should receive rehabilitation treatment continuously for a long period. Rehabilitation treatment prevents joint contraction and muscular atrophy due to spasticity in stroke patients, damaged side, repeatedly performing muscle contraction and relaxation movement so that cells around the damaged brain tissue take over the role of places by the damaged brain tissue. This process enables patients to efficaciously overcome their paralysis. The recovery of activity ability after stroke comprises both natural recovery and recovery through treatment, but predicting the degree of recovery and patient prognosis is difficult. Compared to the recovery of lower limbs activity, the recovery of upper limbs, which performs many complex movements such as hauling and grabbing, is slow despite intensive and long-term treatment. Moreover, the proper use of damaged limbs is restricted in many cases. Among upper limb ability, hand movement plays the most important role in daily life or occupational environmental, greatly affecting patients' movement and quality of life. The hands can undergo serious damage among stroke patients and take a longest to benefit from treatment. Proprioception processes information on limb position and muscle pose through proprioceptors. Thus, the central nervous system monitor and control limb movement and ensure that places, motion, or movements are intensively executed through precise feedback and feed-forward control mechanism. Additionally, proprioception plays an important role in maintaining and securing neuromuscular and balance, as well as reduction new joint damage or functional instability. Proprioceptors are position receptors located in the joint capsules, muscle, and ligaments. Joint and ligament receptors include Golgi-type receptors and free nerve ending and fascial cortical, and which are the most frequently distributed in the body. These receptors recognize not only the signal related to the speed or body movements, but also body parts status of adaptation to provide information and balance the body. Among these receptors, muscle, spindle, and Golgi tendon organ also plays an important role in proprioception. Muscle spindle detects changes in muscle length, and the Golgi tendon plays a role in identifying change to muscle tension. Thank you for listening to my presentation. Thank you.